So very good evening to everyone who are here, and I think Dr. Swati is also here with us.
Yeah,
That is good. Good evening, Dr. Swati.
yeah,
Dr.
good evening.
Swati will be the examiner 1 for today, and I shall be examiner 2. Please clarify if I am clear and audible or not. Am I clear?
Yeah, you are clear. You are clear,
Sure,
Dr.
thank you.
Sandeep.
And candidate 1, are you ready and here with us?
Yes.
Yes, so we shall begin in a minute. Dr. Swati, I shall make you the host, and please let me know how much
Yeah,
time do you need for each candidate, like for the first candidate? Is it
15 minutes, I think the
15 minutes?
same.
So I'll set the
Yeah,
timer for 15 minutes. And just before we start the session, on Sunday we'll have a session at 8 p.m. in the evening, because I had actually requested Dr. Awal to complete her cases, but she is not free at a regular time, that is 11 p.m. India time. So we shall be doing according to her and at 8 p.m. India time on Sunday. I'll post this on the group as well. So please put your reminders for the time. And Dr. Swati, I have made you the host and I've
yeah,
started the timer.
yeah. Now, can you see my screen?
Yes, we
Yes,
can.
I'm able to see.
Yeah. So, candidate 1, you are here.
Yes.
Okay. So, this is your first case, a 10-year-old male who has presented with left-sided hip pain.
Okay. So I'm looking at a frontal radiograph of the chest in a child. The most striking abnormality is I can see within the left capital femoral epiphysis, there is a slippage noted medially. The line of Klein is passing. I mean, if I were to draw a line along the metaphysis, it would be medial to that line compared to the right side. So this is a case of slipped capital femoral epiphysis. I would ask for a frog leg view to confirm and check if it is also seen on the right side, and convey these findings to pediatric orthopedics team for pinning of the pathology abnormality.
Okay. What all other differential diagnosis you expect in this age group?
Other than slipped femoral epiphysis, it could be other differentials.
For the hip pain, I'm asking.
Oh, okay. It could be a Perthes, but that is in around 7 to 8 years. But it's not seen here because there's no reduction in volume of the epiphysis or increased sclerosis seen in that region. If there's hip pain, it could be perhaps a transient osteoporosis of the hip, if it's on and off, depending on the type of pain that the patient is having. But as I can see the slippage on the AP view, my primary diagnosis is a slipped femoral epiphysis itself.
Okay, this is a 65-year-old male who had presented with chest pain.
Okay, I'm looking at a frontal radiograph of the chest in an adult male patient who has come with chest pain. There is an ill-defined opacity noted in the left mid zone of the hemithorax. I'm just looking for similar other lesions, any smaller lesions in the left side or in the right side. There are no such lesions which are seen. I'm just looking for any destruction of the overlying rib. No evidence of missing ribs or destruction of the rib seen. The lesion appears to be ill-defined, and I cannot appreciate the superior border of the lesion. So it may be arising outside the lung, so it could be arising from the rib or the pleura or the chest wall. That's possible. So I will ask for a contrast-enhanced CT of the thorax to characterize the lesion completely and to look for any secondaries, any secondary lung lesions or any secondary rib lesions for further evaluation.
give you the remote control.
Okay, so I am looking at the contrast enhanced CT of the thorax in an adult patient who's come with chest pain. I can see that there is a ill-defined soft tissue opacity noted within the left middle lobe of the lung. No evidence of calcification or cavitation noted within it. Looking for any other lesions within the rest of the lungs on the mediastinal window. So it appears to, there are no other secondaries. I will also check on lung window to confirm that.
You can take the lung window.
Okay.
And it is located in which lobe?
It is located in the left lingular. No smaller secondaries visualized in the rest of the lung. So I'm concerned about primary lung cancer in this patient. And I would also assess for lymph nodes. There were no evidence of, can I go back to the mediastinal window to look at
Yes,
lymph?
yes, you can. You can freely take any of the
Okay.
sections.
So no lymph nodes seen. Just scrolling through, no pleural effusion. The cardia appears normal. No liver lesions visualized. I would also look at the adrenals. Right adrenal appears normal, but I'm not, no adrenal lesions visualized. So basically this, I would like to evaluate this further by asking for a CT-guided lung, the biopsy of the lesion, and refer to the lung cancer MDT discussed with the respiratory physicians for staging, as there is, based on the size of the lesion and there's no evidence of any mediastinal invasion or pericardiac invasion, it would be a T2N0MX lesion. So I would discuss this with the clinicians in the lung cancer MDT.
Okay, the PET scan was done for this patient.
On the PET scan, I can see that there is increased amount of uptake seen within the lesion. So it's basically metabolically active. And this is concerning for malignancy itself.
Any other finding that you're picking up?
I'll just have, okay. Just scrolling through. I can see multiple areas of uptake noted within the liver. However, it was not seen on the CT, so I would normally be able to go back and...
No, ignore them. Look at the mediastinum.
Okay. I can... Looking at the mediastinum, I can see an increased area of uptake within the aortopulmonary window. No other areas of uptake within the abnormal uptake seen within the rest of the mediastinum, so no other lymph nodes.
Would like to see the CT scan again? I'll just show you the CT scan again.
Yes. Retrospectively, there is a lymph node seen in the aortopulmonary window, which was also taking up tracer uptake on the FDG PET. So this would be, I would like to measure it, and on the background of lung cancer, it would probably be N1. There are also smaller lymph nodes seen in the subcarinal lesion. I would be N1 in terms of nodal spread.
Okay, this patient had presented with a 55-year-old male who has presented with jaundice and recent weight loss. There's one portal venous phase image that you're having.
Okay. Okay, so I'm looking at a CT of the abdomen in an adult patient with who's presented with jaundice and weight loss. So just looking at the liver, the surface of the liver appears to be normal, just trying to evaluate for any discrete liver lesions. No evidence of any liver lesions, no dilatation of the intrahepatic biliary system. The portal vein appears normal. Just gonna look at the.
Can you have a look at the lobes of the liver? Can you identify the lobes of the liver?
Yes. So in the left lobe of the liver appears is shrunken with an ill-defined lesion noted within it. So, and this is the portal venous space, and there's an ill-defined lesion within it. So the right lobe does not show any secondary lesions, and just going to have a look. So the portal vein was normal. I'm just going to look at the hepatic veins. I'm not able to delineate the right, middle, and left hepatic veins, although
no, hepatic veins, you can ignore those hepatic veins. They were very well opacifying.
Okay.
You had a comment over biliary radicals?
Yes, the biliary radicals are also, as I'm scrolling, I can see that they are appear to be dilated. So I'm just having a second look at the surface of the liver to see if there is any contraction or retraction of the capsule. And at this point, possibly there is a retraction. So in view of an ill-defined lesion, a very ill-defined lesion in the left lobe with the prominence of dilatation of the intrahepatic biliary radicals and a retraction of the capsule, I'm worried about cholangiocarcinoma. The common bile duct is not dilated. There's no prominence of the main pancreatic duct, and the pancreas appears normal. Just looking at the spleen, spleen appears normal. No obvious. Few varices seen in around the perisplenic lesion. The adrenals and the kidneys are normal. I would also check the lungs in the lung window, but I would be worried about cholangiocarcinoma, and I'd like to inform the physicians, the treating physicians about this. We can do an ERCP for this patient with a biopsy for histopathological confirmation and discussion at hepatobiliary MDT.
Okay. Okay, this patient had an implant and had recently noticed some change in the size.
Change in the size?
Size of the breast, yeah.
Okay. So basically, I have been given T2-weighted images of bilateral breasts where you can see that there are implants within the breasts. I'm just looking at the right breast, and I can see multiple areas of hypointensities noted within them. I'm just also going to have a look at the axilla. I don't see any extravasation or any high density areas within that. So just hypointensities with surrounding hyperintensities noted in the right breast. The size appears, compared to the left side, appears more or less symmetrical. The left breast I'm just looking at, there are a few radial bands, but there is no evidence of similar low signal abnormalities noted within it.
Go ahead, the silicon specific sequence.
Okay. Okay, so yeah, so these droplets, these areas are low signal on the silicon specific sequence as well, seen on the right side and not seen on the left side. No axillary signal intensity lesion seen in the axilla. Since the patient, so this is a case of most likely an intracatheter intracapsular rupture, and the areas which I'm seeing are typical of a salad oil type of areas. So I would confirm and convey these findings to the breast surgeons that there is an intracapsular rupture with no evidence of extracapsular rupture, and yes, basically pick up the phone and inform them.
Is there any intracapsular rupture on the left side, and any other signs that you're seeing?
Yeah, you mean on the left side?
Both the sides.
So on the right side, I see a wavy hypointense line as well, which is in the it's posteriorly seen. So that's a linguini sign, but I'm not seeing anything on the left side. No such area seen. Only radial bands which are normal.
Okay.
Last case for candidate 1.
This 12-year-old patient who had a dislocated elbow, and this radiograph was taken after the dislocation was corrected.
Okay, so this is a frontal radiograph of the elbow in a child. So he has had a history of a dislocated elbow. Looking at the lateral epicondyle, it appears to be away from its normal position. Just examining the rest of the elbow, I would also look at it on a lateral. The capitulum, radial head, internal epicondyle appears within normal position. I would also...
Can you show me which is the medial epicondyle?
So the lateral here, the medial epicondyle is not seen. So trochlea, external epicondyle is seen, but the medial epicondyle is not in position, and it is dislodged and positioned inferiorly near the ulna. So it means that the dislocation, I would compare with previous imaging as well to see the nature of the dislocation, whether it was a posterior dislocation, and pick up the phone and inform the pediatric orthopedics team that the medial epicondyle has been dislocated and is now noted inferiorly, and also look at the lateral view.
Yeah, you can have a look at the lateral view.
Yes, on the lateral view, I can see here that it is in abnormal position. So I will inform them about this.
Shall I stop, Dr. Sandeep, over here? Or
yes, please, Dr. Swati. We are already past time, so just to keep up with the time, I think we should wrap up candidate 1 and then candidate 2. So please go ahead with the feedback and discussion.
Yeah, the certain this MSK cases, you have to be quick, and I think you were quick enough for this patient who had this dislocation of the elbow. So always remember that you pick up with that ossification centers, and you will be picking up the findings earlier in case if you concentrate upon them. So you handle this case very well. Then in this case also, you did mention about all the findings. Even there was rupture on the left side also, as you are seeing this keyhole sign, and there is a signal intensity on either side of the radial folds, which also indicates that there is a small focal ruptures over there.
Okay, I thought those were radial bands.
In case in the radial bands, if you see the signal intensity on both the sides, it indicates the focal ruptures over there.
Okay.
So it was there on the left side also. The right side was quite evident.
Right, okay.
And then here also you can see it is there on the both sides.
Okay.
Yeah, in this case, I think only one window was there, but be vigilant about picking up the findings. You said pancreas was normal. There's a lot of peripancreatic fat stranding. When you're looking at malignancy, do comment over the lymph nodes. There are lymph nodes also, several metastatic lymph nodes over there. The diagnosis was right, and I think just focus properly when you're looking at an abdominal scan. It's like hepatic veins, they were quite normally well opacified over here. So I had to guide you to divert you from that wrong track that you were going. So just like I'm to say, pick up the findings, at least talk about them. Like you are all, you might be under stress or something like that, but pancreas were also enlarged, but you just slipped that pancreas were normal kind of thing. It just slipped from you. Then in this patient, okay, you handled it very well. Look at the lymph nodes properly. The staging was also very properly done. Then, yeah, this patient also, you handled it very well. This would be usually the starting cases, simple cases to make you comfortable with the viva kind of thing. And you did handle it very well. So just be vigilant. You said chest radiograph, like this is that I think that was just because of the stress. That was just because of the stress. I could understand. But that's what, just try to remain cool and calm when you start with your viva. Okay?
Okay. Yeah, I didn't even realize I said that.
That's fine. I think that was all, Dr. Sandeep.
Thank you so much, Dr. Swati. Very good compilation of cases. I think these are the type of cases that usually come in the FRCR viva. Some of these may even come in the long cases, and very good set of cases. And candidate 1, well done. I would give you a 7 out of 8. And the good points about you are that you're confident, you're fluent, you are asking for further images when required, you are comparing with previous imaging when required, and you complete the cases. And one more good thing about you is that you are not using abbreviations, which is good. So you did not use AP window, you said aortopulmonary window. So that is good. The negative points about you, which I feel, are that you need to complete more cases in the given time. There is no point of exaggerating and exaggerating your findings and keep looking at findings. The more important negative point about you, which is quite significant, is that you should avoid scrolling to and fro. Like, I think one of the cases you scrolled it 7 or 8 times. I was counting it. I think that the silicon rupture, that the breast implant rupture case, more than 7-8 times. So avoid that. Some examiners actually get irritated, and that might hamper your marks. Even losing half a mark because of that is not good. Where each half a mark, each mark is so significant. So other than that, well done. You're doing well. You're right on track. Keep doing the same things, and all the best. And thank you, Dr. Swati. So I'll move on to the candidate 2. Let me become the host again.
Shall I stop sharing, Dr. Sandeep?
Yes, please, ma'am. Thank you so much.
Yeah, and well done to candidate 1. All the best for your exams also.
Thank you.
Yeah, so candidate 2, are you ready?
Yeah, I'm ready, sir.
So I'll give you 15 minutes, maybe a 1 or 2 minute extra if required. But then I'll give you few sets of x-rays, few chest lines and tubes, very simple ones. You just have to know the basics and speak whatever you know. If you find something normal, say it's normal. If you find something abnormal, just say it's abnormal. So straightforward ones, be quick and be good. And let me see if I can share my screen, and then I'll start the timer with you. Just a moment, please. Yeah, so everyone can see this chest radiograph. Candidate 2, can you see the chest radiograph?
Yes, sir.
So,
this is chest radiograph of an adult patient. The striking abnormality is a rounded calcified lesion, periphery calcified lesion that's seen projecting over the liver area at below the right hemidiaphragm. No other abnormality I can appreciate. No bony lesions or lung lesions. So this could represent a aneurysm, calcified aneurysm, that is, or calcified liver lesion. Most likely calcified liver lesion. It also could represent calcified chest wall or anterior abdominal wall mass. So in my normal day-to-day practice, I'll compare with any previous images available and with the clinical history of the patient. And if not, I refer patient for a CT scan for better characterization.
Okay, see this case.
Okay, this is a baby gram for, I think, for a neonate. I can't see the humeral heads to assess if he's premature or not. I see a umbilical vein catheter, which is in satisfactory position.
Which one could you please point it out to us? Which one is the umbilical venous catheter? You have the remote control.
Okay.
Yeah, so which one? Okay.
This is the umbilical vein catheter.
Okay.
It's going to the liver, to the left portal vein, and then to the heart, and then that's the umbilical arterial catheter, going to the right internal iliac vein, and then to the aorta. Sorry, to the right iliac artery, then to the aorta, and then ascending up. And it's also in satisfactory position. It is not seen between L1 and L3. There is also NG tube, I think, yeah.
Okay, ignore that. Tell me what are the normal positions of the umbilical venous catheter and the umbilical arterial catheters?
So the umbilical vein catheter should go through the right hepatic, the right portal vein to the right hepatic vein, and
yeah, where should the tip be? Just speak about the tips. Where should it end? Where should the tip be?
It should be at the atrial, at the veno, at the right atrium.
Okay, what about the
through the IVC and the umbilical artery? It should be within the aorta, above, not facing any major branches, so it's not at between T12 and L3, where the mesenteric and renal arteries arise.
Okay, leave the mouse, please.
And it should not be higher than that.
Okay, see this case.
Yeah, so in this case, baby gram of a neonate, there's the umbilical vein catheter appears misplaced, going from the right portal vein to the main portal vein, and to this to the portal vein, rather than going to the hepatic vein and then to the systemic flow. So this is misplaced catheter. I'd urgently alert the referring physician about the finding and recommend the changing of the catheter. I can see here umbilical artery, and the NG tube, I think it's satisfactory in position.
Okay, see this case.
This is very high positioned umbilical.
What is this? Please describe the image first.
Sorry. Yeah, it's a baby gram for a neonate. There is multiple catheters that I can see. There is endotracheal tube, which appear in position, and NG tube also appear its tip at the right, left hypochondrial region. And there is umbilical venous and umbilical arterial catheter. The umbilical arterial catheter appears high in position.
Can you point it out to us? You have the mouse control, and then speak about your findings, please.
So it is extending up to the, I think, the left subclavian artery.
Yeah, what is that?
Branch.
Which catheter is that?
Umbilical artery. So it extends all along the aorta and to the arch, and then it extends to one of the branches of the arch. And the other one is the umbilical vein catheter. It's also appeared low in position, still within the portal vein, and not extending to reach the IVC.
So are you satisfied with the umbilical arterial catheter position?
No. I'll urgently pick up the phone and alert the referring physician about misplaced catheter and recommend change of the catheter.
Okay, see this case, please.
Yes, this is a chest radiograph for a premature neonate, as I can see the epiphysis of both humeri. The striking abnormality is coiled NG tube within the pharynx region, in the neck region. I'm suspecting tracheoesophageal fistula. There is a gaseous shadow in the abdomen, suggesting that it's not like a complete atresia. So I'm looking at the vertebral bodies if there is any segmentational anomaly. I think there is clefts at the upper thoracic region vertebra. However, I'd like to see the lateral view to make sure of if these are real. There is no cardiomegaly.
Vertebrae were normal.
Okay, so there is no cardiomegaly. So I'm suspecting, so it's tracheoesophageal fistula. There's no association with bacterial here. However, I'd like to do skeletal survey to look for any other features. And also I recommend barium contrast study swallow to characterize the type of this fistula. However, first, I'd like to make sure that they are not a misplaced NG tube that's coiled just in the neck because it has been put in the wrong way. And I'll alert the referring physician about that finding urgently.
Okay, good. Could you ascertain if this is isolated esophageal atresia or?
Yes, it's not an esophageal atresia since there is gaseous shadow within the bowel. So it's most likely to be a fistula where there is proximal atresia and distally distal fistula.
Okay, see this case, please.
Yeah. So this is a chest X-ray for an adult patient, chest radiograph for an adult patient. Patient, I can see a pacemaker, dual chamber pacemaker. There is no, yes, one of the leads is showing, I can't really locate its origin at the pacemaker side. So I'm suspecting it may be fractured if the history suggests that. However, there is otherwise along the course, there is no coiling or kinking or fracture seen. There is no definite lung lesion that I can see, apart from mild fibrotic changes seen bilaterally with loss of volume.
Okay, ignore the lungs.
Okay, no bony lesion in the breps or humeri. Slight thickening of the left paratracheal stripe is seen.
Are you happy with the pacemaker electrodes?
Yes, one of the leads appears outside the heart. I think
Which one?
The left side, the left one, appears outside. Not sure if this is just projectional or it's actually outside. But I will worry if there is any clinical concern. I refer patient for CT scan to better localize this.
So the clinician has come to you and he's standing next to you and he asks if he should be worried about this or not. What do you say without further investigation?
Yes, I think we should worry about that because it's not projecting within the heart, it's outside the heart.
Okay.
So, yeah.
Okay, please leave the
even
mouse.
If it's at the,
Okay.
yeah.
Okay. Yeah, have a look at this case, please.
This is just a radiograph for an adult patient. There is an endotracheal tube seen. Low in position. It is directed toward the right main bronchus, totally obstructing the left main
Could you point it out
bronchus.
to us for the rest of the candidates?
Yes, and it's causing complete collapse of the left lung, where I see a mediastinal shift to the ipsilateral side. So it confirms that the white out is due to collapse rather than effusion. So I'll pick up the phone and urgently alert the referring physician about the finding and recommend removal of the tube and physiotherapy.
Okay, anything else in the radiograph?
There is external leads. I can see like the ECG leads. There is no definite lesion within the right lung.
Okay, so you said you would recommend repositioning of the endotracheal tube, right? So we did that, and
yes.
follow-up chest radiograph was taken. Could you describe this for us, please?
So in the follow-up chest radiograph for the same patient, I can see that a new endotracheal tube has been inserted, and it's seen at the tip at midway between the carina and the clavicle, which is satisfactory. Re-expansion of the left lung is seen with no definite pulmonary changes, metastasis changes. There is central line, right-sided central line seen, which appear satisfactory in position at step, I think, in the projected over the atrioventricular junction. And there is multiple external leads that I can see, no NG tube seen.
Okay, please leave the mouse. Have a look at this case, please.
Okay, this is chest radiograph for an adult patient. There is the portal catheter, evidence of Port-a-cath at the right side. However, its step is seen directed upward in the internal jugular vein, which is unsatisfactory. It should go down to the atrioventricular junction.
Yeah, could you point it to us? Could you?
Yeah, it's inserted.
Yeah, could you use the mouse and point it out for the participants?
Yeah, I'm pointing. I don't see it. I don't think.
Yeah, we can see. Yeah, there is the mouse. Yeah.
Yeah, so it's going up instead of going down. So this is an urgent finding. I'll pick up the phone and alert the referring physician about the finding. Otherwise, I can see multiple small pulmonary nodules bilaterally with loss of volume of the lung, mainly of the right lung.
So why do you think that catheter has been put?
Yeah, it indicates that there is a chronic disease or a disease that require a chemotherapy treatment.
So what
and
is
in
the
the presence
disease?
of pulmonary nodules, I am expecting metastasis, and patient have primary cancer elsewhere, and these are metastatic lesions, and patient has been treated with chemotherapy. That's why the port catheter was inserted. Don't see any bony destructive lesion, however, and there is no definite soft tissue in the abdomen to suggest renal or cancer. So I'll make sure that they know about the lung metastasis and recommend change of the Port-a-cath and refer patient for CT scan if he's not known to have these lung nodules, and recommend a new staging.
Okay, so that was done, and this is the follow-up chest radiograph. Please describe this for us.
Okay, this is the chest radiograph for the same patient follow-up. I can see that they have changed the Port-a-cath. New Port-a-cath has been inserted, where its step is seen satisfactory in the atriocaval junction. There is.
So, are you satisfied with the position of the catheter now?
Yes, I think it's slightly higher. However, it does not matter. So I think it's satisfactory. I can see.
Okay, have a look at this case. I think this will be the last case for you. Please describe this chest radiograph.
This is the chest radiograph for an adult patient. I can see the marker is swapped. So the patient has. I have to make sure that the patient has dextrocardia.
Yeah, now describe it.
So the the heart apex is pointed toward the right side rather than the left side, and there is also right aortic arch if the patient is correctly positioned. So I have to check if the marker with any previous images if available on the system to make sure that the patient has already known to have dextrocardia. If not, I'll check with the radiographer.
Yeah, the marker was correctly positioned.
Yeah, and I can see the gas bowel in the stomach seen on the right side as well. So I think this is a case of situs inversus with dextrocardia. I can see any bronchiectatic changes at the lower lobes. So I'll alert the referring physician about the finding and check about the clinical history, why the patient has presented. And yes, and this is the sinus, the skull X-ray. I can see obliteration of both maxillary sinuses. So the presence of dextrocardia with sinus disease, and maybe there is slight bronchiectatic changes in the lung. Maybe not. I'll make sure on the chest CT. So this gave rise to Kartagener syndrome.
You can scroll the chest CT quickly and
yeah. So on the chest CT, I can see yes, bronchiectatic changes seen bilaterally, more on both lower lobes, and there is slight nodules seen throughout the lung. So I'll be worried about this triad will give suspicion of Kartagener syndrome. So I'll alert the referring physician about the finding and refer patient for respiratory NDT as this patient need to be discussed and checked for any also genitourinary abnormalities that may be associated.
Thank you. So your time is up. Well done, candidate 2. I'll describe this first. You described this well, so you picked up the findings on the radiograph quickly, and this was top notch. You quickly saw the marker that was flipped. Now in the exam, they might give you this because this is something we might have in our day-to-day reporting. So this is a common problem that we might have, and the marker has to always be ascertained first before further going on to report the scans. So well done that you identified this quickly, and that was top notch, brilliantly done. And after that I showed you this again. Both the maxillary sinuses are obliterated, so there is sinus disease. And then in the chest CT scan you were good. You identified the bronchiectasis and the tiny nodular opacity scattered in the bilateral lung parenchyma. But in this you also have to describe that this confirms that there is dextrocardia. This also confirms that there is right-sided aortic arch.
Yes.
So these are things you should confirm. And you also have to confirm that the liver is on the opposite side to what it should be. So you have to confirm the situs inversus first. If you're given anything, make use of the entire scan.
Yeah.
So other than that, well done. This case was perfectly tackled. Apart from this, the first case, again, very well done with this case. You were quick enough to notice this calcified lesion in the right upper quadrant. Very well done. And your differentials were good. And calcified aneurysm, any calcified liver lesion, though it is quite large, if the calcification is smaller and a bit lower, you could think of calcified gallstones, but this was a case of a calcified hydrated cyst of the liver. So well done with this. And now coming on to these cases, very well done on the cases. This was the normal position of the umbilical venous catheter as well as the umbilical arterial catheter. Now the umbilical venous catheter, how will you identify the umbilical venous catheter? How could you say the difference?
It does not go down, it just go up.
Yeah, so umbilical venous catheter just goes up. It does not dip below. What dips below?
Arterial catheter.
Yeah, so the umbilical arterial catheter will dip below. It will dip below and go into the iliac arteries, either one of them, either the right or the left iliac artery, and then go up. So the normal position of the tip of the umbilical venous catheter will be at the inferior vena cava and the right atrial junction. So this is at the correct position.
Okay.
I think you were confused a bit about this. So I think the books say inferior vena cava and right atrial junction. This is what Crack the Course says. And what about the normal position of the umbilical arterial catheter?
In the aorta, between not between T12 and L3.
Yeah, so you have to basically avoid the renal arteries and the mesenteric vessels. So it has to be above T10 or below L3.
Okay.
So in my normal practice, I usually see it to be placed above T10. So if you ask, you can say above T10 should be the normal position. So this was a normal case. All the catheters are normal in position. This was just for revision. And this was the abnormal case. The second one, you were correct in identifying that this is a umbilical venous catheter is first going on to into the right portal vein and then into the left portal vein. And this has to be repositioned. So other than that, the Ryle's tube, the nasogastric tube is in position. Other than that, no significant findings elsewhere. So correctly identified, well done in this case. In this case, you got a bit restless and you started with the findings. Always remember that you have to describe what image you have been given. Like you have to tell the examiner if you've been given a CT scan, an X-ray, what you've been given. So even that carries half a mark.
Yeah.
So that you have to remember. Other than that, you did well. The umbilical venous catheter is not in position. It should be somewhere here at the inferior vena cava arterial junction. This has to be repositioned. And this is the umbilical arterial catheter. It is way too high. It has to be repositioned. So well done with this case as well. This was just for revision. These cases, all candidates do remember that this is a pass or a fail case. So these are emergency cases. Any kind of malpositioning should be immediately informed to the referring clinician or the pediatrician. So do not miss. These are as important as pneumothorax or pneumomediastinum or pneumoperitoneum. So remember these. This again, very well done. You are very good at identifying the primary finding quickly. So that is good. This is a coiled tube, and the nasogastric tube is not going inside the thorax and into the upper abdomen. It has coiled here, so that signifies that either it is malposition or there is esophageal atresia. You were good in saying that you will confirm if it is properly positioned or not, if it's properly introduced or not. So that is also something which we should rule out first before saying that it is definitely a esophageal atresia. And you were also correct in saying that it is not isolated esophageal atresia, because you see, what do you see here?
The gas ball.
Yeah, so what does that signify?
Yeah, it's not complete atresia.
Yeah, so there's a fistula somewhere over here, okay? There's a fistula, tracheoesophageal fistula is there, due to which the gas is there. In isolated or complete esophageal atresia without the fistula, you won't see any gas in the upper abdomen.
Yeah.
Okay, so that was correct, well done. And you were also good in saying that you look for the vertebral anomalies. So why did you say that?
Vactral.
Vactral. What is vactral?
V for I can't remember. It's vertebral anomalies, and cardiac, and
no, let's go one by one. So V is vertebral anomalies.
Vertebral,
then comes A.
Anal imperforated anus.
Anal atresia. Okay. Then comes C.
Yeah, and C cardiac, cardiac
then
changes.
TE.
TE tracheoesophageal fistula and limb anomalies.
And R,
and
that is rim. Can you name one or two limb anomalies?
And the radius.
Yes. So radial ray hypoplasia is there.
Yeah.
And polydactyly is also seen.
Okay.
But radial ray hypoplasia, if you say, that is enough. So remember vectorial anomalies, that is a common association with esophageal atresia and tracheoesophageal fistula. So well done in this case. This I had to prompt you.
Yeah.
So this is definitely abnormal finding. This electrode has penetrated the wall of the heart. So this is an emergency.
Okay.
So this you have to know. Like, do not
It could
ignore
not
this
be
finding.
projectional, right?
Yeah.
It could not be projectional.
Yeah, but the thing is, it could be projectional. But the thing is, you have to worry about this, right? You have to make sure that it is not projectional.
Okay.
So if you tell the clinician that it could be projectional, you just ignore. So that is a fail, definite fail.
Okay.
So even if it's projectional, in normal practice it could be. But for exam purpose, I don't think they'll give you a projectional X-ray.
Okay.
But whatever be the reason, you have to make
Yeah.
sure you have to tell the clinician that this is an emergency, it's a possible emergency, and we have to rule out if there's penetration
Mm.
of the cardiac wall or not. So that is the key over here.
Okay.
Yeah, and one more thing I would like to add, Dr. Sandeep,
Yes,
over
ma'am.
here. In this case, I think even she would have said she could have said that I would compare with the previous radiograph for the positioning of the lid, and in case if this is a lid migration, their patient might have presented with some emergency, like kind of rhythm abnormalities at present. Like this could be one of the presentation why the patient has presented when lid perforation is offered.
Agreed. That agreed. But also remember that these type of perforations are usually immediate complications of cardiac pacemaker insertion.
Mhm.
So what Dr. Swati said, do remember that, and that is a very important point. Other than that,
Yeah.
okay, you reached the diagnosis at the end, but I had to prompt you.
Yeah.
And this was again very well done. You quickly identified that the endotracheal tube is not in the correct location. It's in the right main bronchus, and due to which there is complete atelectasis of the left lung, because of which there is complete opacification and whiteout. So you have to inform the referring clinician to reposition this, and this was a follow-up, and this now is in position. Okay, so this again, you were very prompt in understanding that something is wrong with the position. It should not go up like this, and it has to end in the superior vena cava. So we have to reposition this, and we had repositioned this and showed you later. And again, these are multiple opacities in the bilateral lung parenchyma, which are metastasis, lung metastasis, likely due to some primary somewhere. So this patient actually had a renal cell carcinoma, due to which there were these lung metastasis. So well done with these cases. And I think I showed you one more case. We've
Yeah.
already discussed the
Mm.
this case, right? Or we haven't?
Yes.
So
Yeah.
we've
Yeah.
already
We have.
discussed this case. So this was a case of Kartagener syndrome. So very well done. All in all, you did well. I would give you a 7 or a 7.5. You are confident, you are clear, and you have good knowledge. You complete the cases, and the best thing about you is that you pick up the emergency findings and you say that you will inform the referring clinician uh, urgently. So that is good. One negative point which I thought about you is, do not think that the findings are due to projection abnormality or could be an artifact. So for exam purposes, at least, wherever you find an abnormality, a significant one, an emergency one, so make sure that you will convey to the examiner that you are worried about it. Other than that, well done. Dr. Swati, do you want to add something?
No, I think she did very well. Only one thing in esophageal atresia case, you said that you will confirm the finding with barium, this thing. There's no need to do barium pouch, this thing in a baby. Whatever
Exactly.
they use, usually water soluble contrast. And you could have also said if there's a clinical history of regurgitation, which will confirm the finding of esophageal atresia rather than malpositioning of the tube, that would have also sufficed actually. But in case if you have to suggest an pouch gram, it is a water soluble contrast.
Exactly.
Not
So
the
we do not use barium in
Yeah.
pediatric age group. So we use water soluble contrast. We used to use iohexol. So
Yeah.
that is what you have to say. Other than that, well done. Candidate 2, both the candidates were very good today. And Dr.
Thank
Swati,
you, Dr.
great
Sandeep
as
and Dr.
usual. And we are done with today's session. And I'll share the recording as soon as I am done uploading this. And regarding Sunday's session, I would just like to inform you all again that the Sunday session will be at 8 p.m. India time. I will also share the UK time on the group. So thank you so much and good night to everyone.
Thank you, Dr. Sandeep. Thank you all.